Can you hear me?
Yes.
Okay. I need to transfer to the other one. Great, thank you. Thank you for having me here. Thank you, Fred. It's great seeing you again. So the topic of implants in the aesthetic zone, we could be here for a week. There's so much to cover, but I want to cover some key aspects of successful placement of implants in the anterior zone, particularly the interdisciplinary approach. So a little bit about me. I'm from Annapolis, and it's a little bit further than I thought it was going to be out here, but it was a beautiful trip anyways. Enjoy spending time with my family, on the water, in the boat. I'm also very blessed in that I have my son-in-law is my partner. He's doing a great job. It's been fun to work together, and also I get to lock my daughter into the area she can't move away, so that worked. And especially now that we have a new baby. It's Parker, and she was helping me with the lecture presentation, so lots of fun. I've been involved with the Seattle Study Club, and for those of you who don't know, the Seattle Study Club, it's about interdisciplinary care, comprehensive treatment planning, and community, dentists getting together and supporting one another. We've lectured at their national symposium multiple times with my interdisciplinary group here. These are my good friends and colleagues, and we've worked for years in how to deliver interdisciplinary care at the highest level. I've had the opportunity to lecture with world-renowned speakers on their platform. It's been a true honor. And there's our team. We are wearing Maryland ties. We were having a competition in treatment planning. So, why is interdisciplinary dentistry important? When we work together, we can see more possibilities. When we get focused in ourselves, everything looks a certain way. So if all you have is a hammer, everything looks like a nail. So when you go to lectures, you're going to see some amazing pictures. All of the things that I'm going to be showing are everyday cases. So when you look at these outstanding results, they've been redone 10 times. That's not the reality. You don't do that in practice. Really what you want to do is nail it the first time. Now, failures are a reality in dentistry. That's the mark of a true dentist. If they've been out for 5 years, you've seen some things fail, you realize that's just the way it is. But a lot of times we place the blame on ourselves. That is our technical skills that weren't good enough. What I've found is it's really not so much that we don't have the skills, it's the diagnosis. Were we doing the right thing? Did we miss something? Now, in addition to being a dentist, I'm also a pilot. And so I'm big into checklists. And really, if anyone hasn't read this book here, the Checklist Manifesto, it's a quick read, but it's really impactful. And it talks about using checklists to create a safer environment. And in aviation, we've been doing that for ages. That's why you get on a plane, you might not get through the lines through TSA, but you know that you're probably going to land there safely. So in the book, they talked about the Boeing 299. This was during pre-World War II, a plane that was so superior to any other aircraft that was being built, and it just needed to be approved for use. Everyone thought it would be approved. What happened was, in front of the big brass for the test flight, took off, leaned to the left, and crashed in front of all the generals. They scrapped the project and moved on. But some pilots decided that this aircraft really needed to be brought into service. So what they did was they sat down and they figured out everything that went wrong with that flight. But when that plane crashed, they had the best technology, best performance. The pilots were the best. And why did it fail? This is a gust lock on my plane. It just protects this little aileron. They forgot to take it off. Did they know they should have taken off? Yes. But they were focused on all the other complex things that were going on at the same time. So that was the birth of the checklist that has given us the aviation industry that we have now. So, what's the problem with checklists? We don't like them. Checklists make us feel like we don't know what we're doing. We feel above it. We feel that our skills should be able to allow us to do things without a checklist. But maybe we need to rethink that. In the checklist manifesto, they talk about a 19-question, 2-minute checklist for surgery. And they found that by using that checklist, complications fell 36% and deaths fell 47%. That's amazing. If we had some drug that would do that, it would be a blockbuster. But still, we don't like checklists. So in the aviation industry, checklists are part of culture. Everybody expects it. In our office, we have a checklist for every single procedure that we do, and I insist that the assistants follow it. And when we do this, we catch things that would be a problem. I was tired of walking into a room, starting my procedure, and saying, oh, where's this? Where's that? Why isn't it out? Now they have to read off that checklist. So in treatment planning, we've developed a checklist in order to make sure when we're dealing with complex cases that we're not missing something. And when we're dealing with something as difficult as implants in the anterior aesthetic zone, we really need that checklist because mistakes are a disaster in the front. So this is our systematic treatment evaluation protocol. And what it is it's a checklist. Start with doing adequate assessment, your exam, diagnosing, then analyzing, then communicating to the patient, and then implementing the process. And we will do assessments in these 4 categories. Now, this is similar to SPEAR or COIS doing facially generated treatment planning. But it's important that we have a diagnosis in each one of these areas and we don't forget to do that. So we'll have a diagnosis of tooth position, gingival characteristics, smile mechanics, TMJ, occlusion, teeth, perio, and endo. And then we'll analyze the aesthetics. And what we've done is we've developed a PowerPoint template that has all of the steps that we need to be looking at on there so that it's easy to treatment plan. And we'll walk through this so you can see this. Again, we're getting a facial diagnosis, a dentofacial diagnosis, and then a dental. Frequently, we focus here as dentists, and we sometimes will miss other issues. Then using the template, we can come up with our plan and go from there. Using the template, it also allows us to communicate to the patient what we are going to propose, what we can expect, what might be a limitation. And then we implement that. So again, here, when we're looking at particularly a worn dentition case, by applying these crosshairs, we can determine where the incisal edge belongs, and we can put together a case and see where we should be putting the teeth. All of the information that's in this template is from Spear, DSD, Pankey, Dawson, American Academy of Cosmetic Dentistry. So all these principles are there. And it's just like those pilots, though, that forgot the gust locks. You may know about it, but the question is, are you going through it step by step as you're doing the treatment? Because when you miss something, you can have catastrophic results. So here's the checklist. We're looking at facial symmetry, midline, incisal, occlusal cant, facial profile. We're looking at facial thirds, and here are the lines, making sure we don't have vertical maxillary excess. Looking at facial symmetry. Also, we're looking at profile. We're looking at particularly lip support. Then we move in looking at the lip dynamics. And when we're looking at this patient, she does not have an adequate display of teeth at rest. So we need to bring that into our treatment plan. This becomes really critical when we're placing implants in the aesthetic zone, because once you put the implant in, it's very difficult to move it. So these are some norms. We're looking at 60-year-olds should be displaying at least a millimeter. Then we're looking at the lip dynamics, lip mobility. So how much gingiva do they show? Too much? Not much. When we have a low lip line, we can get away with a lot. When we have a high lip line, it's amazing when they start to smile with their new teeth, and that smile's a lot bigger than you thought it was. We're looking at the incisal plane. Transfer the midline from the full face to the dentofacial. Then we're looking at incisal plane, determining where it should be. The occlusal plane should roughly follow the lower lip. So we draw that in. So we can see in this patient where we have a deficiency here. So here's our midline, or our ideal incisal length. Then we're going to look at tooth proportions. Roughly 0.81 is the proportion. So, and when we're looking at a photograph as opposed to 3D, it's going to diminish as we come around the curve. But this chart shows you roughly what we should be displaying. Then we also want to look at the gingival height. Make sure that's level. We're going to look at the papilla heights and the zenith. So following all of those checklists, you take that case, and this is an immediate implant right here. You had non-restorable tooth. Could have just placed the implant in there. Maybe the patient would have been happy because they walked away with what they started. But really, it's a comprehensive case. This patient is much happier with a full restorative makeover with correction of the gingival margin, correcting of the midline that's canted. This was done as an immediate implant placement, but the height of the implant was determined by the plan, not by the existing position of the teeth. But one of the things that happens when you do this type of treatment planning is it becomes obvious to both you and to the patient areas that need to be treated. We're looking at all of the mouth. And it makes your treatment presentations that much more effective. So again, here's our template, which we're going to walk through on a case. The photographs are inserted. And this is a key element. This is our template. This is proportional teeth in PowerPoint that can be stretched, modified to overlay the teeth. So we're going to walk through this here with a complex case that could be considered just a single tooth, but really when we're looking at it, there's a lot more involved with it. So John, camp counselor, came in and said, I have a problem. I have a loose tooth. When we actually talked with him and mentioned, how do you feel about how the teeth look? He says, well, I've always lived with it, but I'm kind of a little bit ashamed of it. And now we have to do something. Are we going to leave him where he is, or are we going to actually do what he would like to have? So that tooth is fractured, subosseous, not restorable. Medical history is really non-contributory, Lyme's disease. So here we're going to go through 6 basic photos that we need to take. We put them into the template. We want to have lips at rest so we can see the incisal display, and a full smile so we can see what the lip dynamics are. Right and left lateral smile, cocktail view. This is very important. We want to have teeth together, teeth apart, and you'll see why that's an issue. Lateral views, full mouth series. Perio really is non-contributory in this case, but it was evaluated. Soft tissue evaluation, we go through full checklist, make sure that everything is where it should be. If it's not, we're going to be treating it. Occlusal analysis, muscle analysis. Nothing worse than someone coming back after you've done a restorative case and they say, my joint's hurting. But it was there before. And if you have it documented, that makes it, you're able to explain to the patient that they had a problem before we started. Charting, identify all areas. Now we're going to take a look at that, and what do? So just take a moment. In your practice, this patient shows up. What are your treatment plans? Take it out, put an implant in, let him go home. A couple of challenging dilemmas that we have. The incisal positions are irregular. Gingival levels are all over the place. And the other thing is there's no room to put restorations in here. So we have those challenges. But we'll go through an analysis and we'll overlay the template and you'll see how the treatment plan was formulated. Again, We do have a diagnosis as written in each one of these categories as part of the checklist. Now, when we're doing facially generated treatment planning, we were all taught that we should start by treating infections, then we'll repair the teeth, eventually we'll get to the occlusion, and maybe at the end it'll look good. And really, when we're planning, we want to start with the end in mind. What do we want it to look like? Then we walk back and say, will it function when it looks good? What is the occlusion going to be? Then we're going to look at the structure. What do we have to work with? How badly broken down are the teeth? How much bone do we have? And then we'll deal with the biology, the perio, the bone, and any infections. Now, we treatment plan backwards, but we always do treat the way we were taught. So it's important that we're not advocating we jump in and do cosmetic procedures before we've treated perio. We are just planning the case. Where do we want to end when we're all done? And then we backfill. So again, that whole checklist is in here. This is the template. I don't know if this is showing well. Can you see these lines? It's a little bit bright in here. So we're looking at our facial thirds and facial symmetry here. The template has all of the areas that you want to assess on the side. So it just kind of prompts you to look at it, and looking at proportions, and it tells you the mid-face, lower face should be about equal. The distance between the nose and the upper lip should be about a third to 2/3 below that. Just keys you into what it should be. One of the things when we did our presentations, we were working with an orthodontist, and this view became rather critical. We didn't always look at this. And in this view, what you're looking at is the lip support. You want to know whether they're under-supported or over-supported. Because when you're going to be putting restorations on there, you want to know how much are they going to be able to tolerate there. So his lip is slightly under-supported, which will become a factor as we go through the treatment. Again, all of these are written on the side to prompt you as to what you're looking for and determine what the diagnosis is. Now we're getting into the dental facial. This is the lip dynamics. And here, all of what we're looking for example, the incisal edge display, 30-year-old, 60-year-old, upper lip norms, lip mobility, what do we expect on average, differential diagnosis for vertical maxillary excess. It's all right there on the template. So when you put the photos in, everything's right there. All you have to do is answer the questions. Now we're going to lay out our crosshairs, and these lines are all in the template already. And all you have to do is just grab the lines and move them around. And PowerPoint works very well with curved lines in dentistry. So here we have our occlusal plane, and when we just lay it in here, we can see that we have a discrepancy with the incisal edge with the posterior occlusion. Our midline looks reasonably good. When we look at our gingival levels, we can see we have recession here and here. We have excessive gingival display over the incisal, over the central incisors. Then once we have those lines drawn, we lay over this template, and we can see where the incisal edges should be. And this can be shown to the patients, and you can manipulate it with the patient, and you can explain why we want to do the treatment that we're proposing, as opposed to them saying, you just wanted to do 6 crowns. Now they can see why it needs to be done. And do the same thing with the lower. I like having it without the fill in it because you can really see where we're off. Now, this is why it's important to have both teeth apart and teeth together. Because when we look at where we want to put our incisal edges on this case, that's going to be a problem because there's no room to put those incisal edges there. So we need to figure that out before we put that implant in. Well, there are 7 ways that we can create restorative space in the anterior. 4 of those are ortho. We'll go through them. You can intrude the maxillary anterior, intrude the mandibular, you can procline. That's assuming that you have adequate bone structure and the lip support is not going to be compromised by that. That's why the lateral view is so important. You can recline the mandibular teeth. You can open the bite by doing a full mouth reconstruction, at least in one arch. You can also equilibrate the case so that you, in the horizontal direction, you can, by moving from their centric occlusion to their centric relation, you can pick up a millimeter or 2 in some cases. And then there's crown lengthening. We could crown lengthen the teeth, possibly need to do elective endo. So the decision on all of those is based on where the teeth ought to be. And we've showed all this to the patient. So, mounted models, do these digitally now. And there was a significant CRCO slide, which was equilibrated to create some space. But ultimately not enough. When we look at the occlusal view, you'll see that the buccal corridor is out here and we're deficient here. So that those incisal edges are actually where the cingulum belong on those teeth. So if we draw it out, we can add, and we know that we can do that because his lip is deficient, and we'll tolerate that. Do a wax up. This is a lot easier with digital technology now. That can be done very quickly. And then we overlay it, and here's what our plan is. We're going to be adding and creating overbite, placing the occlusal contact on the incisal edge, and it will essentially duplicate the cingulum. So here's our case. We're looking at that for whether we can place the implant. Do a periodontal evaluation. We want to classify the recession as Miller's class 1, 2, 3, or 4. Right, Fred? And significance of the Miller's classification, we're not going to be getting into this because that's a whole nother lecture on grafting, but it tells us whether or not we can gain root coverage on that case. And a quick way to do this is to slide the probe horizontally to the attachment, and that's the highest you'll be able to get your attachment, predictably. So looking at this, what we want to do, we can see, we want to add some gum here, take some gum away here, add some gum up there. And then we communicate it to the patient. Now they understand why do we need to do all this work. So we can place the implant where it belongs. we can just put it the way it is. We can put it where it should be. Do a 3-unit bridge. So we did a mock-up. Again, much easier to do this with a digital technology now that can be prepared very easily as long as it's additive. Allows patients to see what we can do. He saw that, and really, after going through this whole process, he took this picture home to his father. He could not afford this work, and he asked his father for help. And so many patients will find a way once they know why it's best for them. So that's why this is so powerful, because you can communicate why they should be doing the treatment. They can see it. And then we do the treatment. So, did a provisional, mocked it up. The coronal aspect of the tooth was removed. The provisional helped to support that tissue, very critical. Once you lose the tissue, and we'll see a little bit later on how difficult it is to get it back. Incisal edges were established in the provisional. Soft tissue was maintained. And then we went to implant placement, gingival grafting. Now we've got our gingival levels where everything belongs. Here's our implant, soft tissue, then developed, supported. Here's our final restoration. So, any questions on any of that? Just flew through a lot of information, but the key point is that there's techniques for doing immediate implants. But the question is the implant the right thing to do, and how do you know what the right position to place the implant is? And you really need to go through this. And what you'll find is, very frequently, a single tooth case is a lot more than just a single tooth. Okay, so what do you do when an implant's already been placed and guidelines weren't followed, and we have implant that's looking a little bit more like a tusk? In these cases, when we have a misplaced implant, the best thing to do is just remove it and start all over. Because we're going to go through a case, and sometimes patients won't agree to that, even though you explain everything. It's very difficult to recover from a misplaced implant. So ideally, remove it, graft it, and get an implant where it belongs. So this patient, Barbara, hated this tooth, and you can see why she would hate it. It shows in her smile. And I had recommended, went through the whole process, showed her the overlay. We should remove this implant, rebuild, start from scratch, and she just couldn't bear the thought of taking that implant out. So, we'll go through how difficult it is to correct a misplaced implant. So, doing gingival grafting, this is a checklist that I have. First thing we want to know is, what is the desired position of the gingival margin? And that's with the whole workup that we went through with the step protocol and the template. We need to determine, where do we want that tissue? And the next question is, can we get it? And that's getting into the Miller's classification. This is the attachment level on either side that tells us whether we can achieve it or not. What's the condition of the exposed root? So can we get coverage? So we cannot cover over a crown. We may be able to cover a root, but we can't cover a crown. And when we're talking about dental implants, the materials are very critical because you can get soft tissue adherence to titanium and to polished zirconium. You cannot get it to porcelain, you cannot get it to gold, you cannot get it to glazed zirconium. So when we're doing gingival grafting, it's very important to know what we're putting that graft up against. And also when you're doing your implant restorations, the materials are very critical. Anything that's subgingival needs to be titanium or polished zirconium, nothing else. And then what is the position of the root relative to the alveolus? So that other implant we were looking at was buccally displaced. Very hard to get a graft to move outside of the alveolus. That's why a buccally misangled implant is so difficult to restore, because it places the head of the implant outside of the alveolus. Very difficult to graft. And then what are the aesthetic versus the functional requirements? So take the case and we do our template over there, and we can see that right here there's going to be a deficiency, and we can show this to the patient. Now we can also see what would happen if we were to lengthen the teeth. It would be not such a difficult case. So now we're not talking about grafting a tooth, we're talking about restoring the anterior 6 teeth. So when we look at this, the Miller's classification, we have a deficient attachment. So when we look at this papilla height here and this papilla height here, those papilla heights are not going to substantially change. And we need to work with that. So if we were to try to cover this crown, we would not be successful, because we're not going to get any tissue adherence to porcelain. And then what's the position of the root for implant relative to the alveolus? This is outside of the alveolus. So, this is an exercise of what you don't want to do, but in the end, she was pleased with what we were able to achieve. So we took the crown and I converted it to a screw retained with a screw access through the buccal. And we need to bring the buccal aspect of it back as far as we can. So I recontoured. Polished the existing abutment, re-cemented extraorally. So now we have a screw-retained crown and a large piece of tissue here from the tuberosity. Grafted that in there. Now, that was not enough. And the reason is that when a tooth or an implant is outside of the alveolus, you have two choices. Either bring the tooth into the alveolus or bring the alveolus outside. And so in order to graft this beyond that connective tissue graft, we had to augment the whole area. So when we did that, that provides the stability for the graft to keep it in a coronal position. Again, photos, you always see your mistakes. This is a vertical mattress, and this one was interrupted, and the suture pulled right there, and it'll come back to haunt me. But here, when you look at this, you can see the volume that we created out here that supports the graft here. Without that, it's going to recede. So I always say we're building sandcastles, not skyscrapers. You have to have a really broad base when you're doing soft tissue grafting in order to have stability. So the graft needs to be large. And here, when we look at it, not bad. But looking at our original plan, that was the deficiency that we had anticipated, and there's the deficiency right there. We communicated to the patient, this isn't a failure. The patient was on board, she knew what she needed to do. I think it was an awful lot of surgery. Would have been a lot easier to take that implant out. But again, looking at doing comprehensive treatment planning, we saw that what this required was restoring these teeth in order to alter the gingival levels. So rather than jumping in and starting the gingival graft without having our end in mind, we had a reasonable expectation of what we could achieve. Miller's classification, and this is something to keep in mind. When we're looking at implants, or gingival grafting, it's what's the adjacent attachment. So here, we had an implant was placed, and there's a lot of soft tissue that was lost. And this is a real problem when we have exposed roots here. So getting root coverage inapproximately is quite difficult once that attachment is lost. So gingival grafting, critical part of implants in the aesthetic zone. You need to have tissue volume. And so here, what we did is, this is a C graft. So this wraps from here to the lingual, and then this one wraps here around to the lingual. So two large pieces, and then repositioning. And we were able to get some of that root covered, but there's a deficiency right here, and I begged her to let me just put one more piece in there, but she said this was good enough. Another issue with placing implants in the aesthetic zone is you're dealing with limited space, mesial distal. And when you have a failure of an implant, it's going to impact the adjacent teeth. Once this attachment is lost, it is very difficult to recover from. So we have to be very mindful when we're placing the implants that we don't violate the minimal tissue volume that's required. We'll go over that in a little bit. So here, we did replace the implant, and I did 2 C grafts, and this time I learned I put the third right down the middle so we maintained the volume. And here, when we looked at the recession that was there, good result. And deficient papilla. We were able to communicate that to the patient before we started, not after. Here's another one. These cases are ones that have been referred after the implants are placed. 2 implants adjacent to one another. This is a real challenge because that papilla is already deficient, and recovery from this is quite difficult. So I'm going over these cases so that you can see why it's so important before you put an implant in to avoid these problems. So we buried the one implant. What I would do now is I would remove it because there's vasculature there. So when we have the implant in there, that titanium is occupying blood supplies. And with implant removal tools, I can generally get implants out atraumatically in just about every case. So we don't have to try to find them out, and we don't lose bone. But we buried this one. And then after the original graft, it wasn't quite enough, so I tunneled, used alloderm, we used bone morphogenetic protein, the BMP, and I went as far as I could go and created a Mugford's tumor here. But as things started to retract, you have to really overbuild in order to get that tissue, to get that papilla right there. That was a tremendous amount of work to get that papilla back. So here we are. And we're able to reconstruct that. A lot of surgery. In the middle of all that, this tooth had external root resorption, tooth broke off. And if you look at it, here's the implant that was placed with all the grafting, and this one was done as an immediate extraction and implant placement and provisionalization. And when you look at the soft tissue around that, it's better than the other areas. So that leads me to really the gold standard. Gold standard for placement of implants is as long as the tooth is in the right place, as long as the tissue is where it belongs, preserve it. If you have it, don't lose it. So this is really no longer risky business. I've been doing immediate implant placements really since the 90s. I recall Dennis Tarnow chastising a group of people saying, never ever do this. He now has a book on it. But really, the principles, when you understand them, they were foreign to us at first, but it makes all the sense in the world. So let's take a look at this case here. Trauma case, vertical fractures on both teeth. So when we're placing implants in the aesthetic zone, one of the things is that the head of the implant needs to be placed at least 3 millimeters below the buccal gingival margin. That means the head of that implant can be almost 8 millimeters below the papilla on the interproximal. So when we were originally placing implants, that was frowned upon. We were going to create a periodontal defect. Can't do that. So the question is, will that deep placement cause periimplantitis? And the other question is, what do you think about putting an implant in and having all that space out there? Is it going to fill it? The answer is yes. Absolutely, if you follow the right principles, it will. And it makes all the sense in the world. So this is typically the cases that we'll see. This was in 2008, 2010, 2018. And this is what we'll see for bone. And the heads of those implants are 8 millimeters below the papilla tip. There's no pocketing. Paying attention to all the details, occlusion, contours, and especially materials. The other thing that we really want to have, critical for deep placement of implants, is an excellent connection. If we have any mobility in the connection, what will happen is the soft tissue attachment will migrate below that loose attachment. So conical connections in deep placed implants is critical. So tons of cases, thousands, and this by far is the most predictable, healthiest implants long term when we do it this way. So why is that? So So when we look at this, you can see, in this case, you can see the different zones around an implant. So we have the hemidesmosomal attachment. So this is where the long junctional epithelial attachments will actually adhere to the abutment. If you get an attachment to the abutment here, the tissue will not migrate to the side of the implant and cause bone loss. So this is critical. And then this is your sulcular epithelium. You can see it right here. So basically you probe to here. And this is what you'll see on these cases if you set it up where you're using the right implant, getting the right contours, the proper tissue volume. This can be done predictably. Since these areas have been defined in various articles, everyone's got a different name for it. Sulcular epithelium, junctional epithelium here, connective tissue down here, zones, critical, subcritical. You just need to know what they are and what they represent. So basically, it's the soft tissue around the implant. You have to have connective tissue. You have to have an epithelial attachment, just biologic width around teeth. Implants have it too. They're just a little bit different measurements. So when we look at, this is an old article, this I believe also was Dennis Tarnow, where a external hex implant, basically these are the dimensions we need to have. And you see this cratering around the implant. We were told that's normal. That's what you're going to get around an implant. And that cratering has a big part why we have these measurements. But when we look at the soft tissue here, you don't get this cratering. The soft tissue is supported. So again, critical is the connection, because if we don't have a solid connection here, the movement is going to cause the attachment to move from the abutment down onto the implant. When it moves down onto the implant, you'll have bone loss. You'll also then expose a portion of the implant surface, which is rough. It's much more prone to periimplantitis. So, BioHorizons as a workhorse. I've used it for ages. Absolutely, their standard connection is the best non-conical connection out there. Their laser lock helps to prevent that epithelial downgrowth. But with their new conical connection implant, this is the premier implant, absolutely, for immediate implant placement. The thread design on the BioHorizons is not excessively aggressive. You get good compression, so when we're doing immediate placements, the implant needs to be able to achieve stability. And the design always for the BioHorizons, I've placed many different brands of implants, but the BioHorizons has always been, predictably 95% of the time I can get primary stability with the BioHorizons. Whereas other implants, it's a little bit more questionable, somewhere around maybe 30 to 50%. But the conical connection has been exquisitely engineered. This is a 7.5 millimeter, or 7.5 degree Morse taper, so this locks in. There's no movement in here. There's a deep connection. We have a platform step here, so that we have attachment here, not migrating down to here. On top of that, no other implant has laser lock. I don't know if anyone's familiar with laser lock. The laser lock is the only implant that allows for true connective tissue insertion perpendicular, like to a tooth, so that it will attach here. All of the other implant systems, you have circular fibers that essentially will wrap around it but not attach. So the stability here is great. Why is that important in immediate placement? Well, I'd love to say that every single time I put it in, the bone's going to grow right to the top of that implant. Sometimes you might fall a little bit short. I have no concerns when I have a laser lock attachment here. We don't get the tissue moving down. We're not going to get bacterial accumulation on this surface. So really when we're looking at this, the Bi-Horizons conical ticks every single box as far as the ideal implant to use. So here you can see soft tissue moves down onto the implant, whereas with this connection here, it stays up, and the attachment, as long as the abutment is appropriate material. One other thing I would recommend is always use original manufacturer's parts. And Vulcan is the milling component of Bi-Horizons. They do a fantastic job, and you will have titanium where it belongs. So we don't want to bring the restorative material down. Remember, you need to have, the abutment is actually a part of your implant. It has to integrate into the tissue. This is showing laser lock here. These laser lock channels were very specifically designed so that the cells will migrate and lay down matrices in there. Okay. We talked about complications. We don't want to have them. Checklists are always what you need to have. So, for implant placement, one of the things I have my STC, slow down, cowboy. Okay. Just hold it, because when we see that patient coming in at 3 o'clock and they've broken off the tooth and they say, "I've got to go to work tomorrow," you might be tempted to just jump in there and take the tooth out and professionalize it for it and be the hero. But maybe you won't be. So, questions I always ask: can I save or use the tooth? Implants are great, teeth are better every single time. Sorry, Joe. But is the tooth to be extracted in the right place? We went through all of that with our workup. You really need to look at it and not be fooled and not get blinders and just see the broken tooth. And then, can I achieve the ideal tissue dimensions? This is critical. If you violate the tissue dimensions, you're going to have failures, bone loss, recession. So, let's take this case here. This patient presented for periodontal disease, and we went through and did lay-nap. Very successful reduction of pocket depth. The patient was not pleased with this result, though. And so, regrowing the papilla, we just looked at how hard it is to regrow a papilla. So, options that we might have for regrowing that papilla? Any thoughts? So when we're looking at regrowing a papilla, bone grafting won't do it. Gingival grafting, we can fake a papilla, but it's limited. The only thing that will regrow that papilla is orthodontic extrusion. So if we extrude these teeth, we will carry the bone down with it. And so that's what we did. And we told the patient, here's what we're going to do. We're going to extrude both of these teeth to the point of extraction. So we did elective endodontics on these teeth. And we started to extrude. Patient knew full well that these teeth were going to extrude, extract one. We were going to root bank the other to hold the tissue in order to maintain that papilla. So we started here, we went through the orthodontics, and we extruded everything. And then we stopped and said, wait a minute, do we need to take a tooth out? And actually, things lined up pretty darn well. So if we skipped this step and just kept on going with our original plan, we probably would have worked. But I think this worked better. So here we provisionalized. Here we had also recession up here. We grafted that area. So here we started. Here we are. Splinted crowns. And we eventually got, I think something like 8 years later, that last area covered. But implants great. Teeth, you don't want to give up on them. This patient came in recently, and I was actually really shocked. Fred, I know you do a lot of full arch cases, but tell me, would you edentulate this lower because the patient wanted whiter teeth? But that was the plan. This patient came in, he had a denture, and he was scheduled the following week to have these teeth removed because he wanted whiter teeth. It's out there. Yeah. All right. So here's our friend John. Is the tooth in the right place? Go through. And this is a big issue that we see. If you don't put the implant in the right place, so the head of this implant, if you look at it, belongs right there in order to get the proper emergence profile. Implant was placed too shallow, and then a ridge lap was done. And of course, I wound up seeing this patient for periimplantitis because of that. Go through our checklist. Okay. Third step, can the ideal tissue dimensions be achieved? And this is one of the ones we have to, there's no exception on this. The implant must be placed 3 millimeters below the buccal gingival margin. Why does it need to be there? Because we need to have 1.5 millimeters connective tissue, 1 millimeter of epithelial attachment, and then 1 millimeter sulcus. You have to have that. 1.5 to 2 millimeter gap between the implant and the bone. So early on in implant placements into sockets, the thought was fill the socket with the biggest implant. Problem is that thin bone, which is somewhere between maybe about 0.5 millimeter, maybe a millimeter. Millimeter would be a lot. There's not enough vasculature to that bone. It goes away. You need to have 2 millimeters buccal. You need to have attached gingiva. You need to have at least 3 millimeters of keratinized gingiva so that you don't have a retractable gingival margin. Again, as you're looking at a case, check the zone of attached gingiva. And so you're looking at, really, from the buccal aspect of the implant to the tissue, 4 to 5 millimeters combined thickness. So when you look at your cases, the ones that look great, that's what you're going to have. You've got 4 to 5 millimeters tissue thickness to the buccal of the implant. So there's plenty of studies out there that shows that the critical buccal bone width, when they placed implants closer and closer, you need to have at least 1.5 millimeters of bone. To the buccal, it's 2 millimeters. You really need to shoot for 2 because you're going to get some resorption. Soft tissue is critical. So we look at zero bone loss concepts. This is, what they found is that when you have thin tissue, less than 2 millimeters, even when the implant's placed properly, you will lose bone. You need to have at least 2 millimeters thickness, and it's ideally 3 millimeters vertical height. And this is not just in the anterior, this is on every single implant. So, when you're placing implants in areas with thin tissue like this, it requires a gingival augmentation. Two millimeters tissue thickness. Another interesting thing is studies show that if you have 2 millimeters of gingival width, you don't have to worry about the color of the abutment shining through. So there's a lot of zirconium abutments and anodized abutments to try to not have that show through. But really, if we're looking at what we're looking for is to have adequate gingival width. So if you don't have it, grafting is required. Extraction, critical. So you don't want to fracture that. You don't want to have a green stick fracture. So very careful luxation, rotation. I use a tool called an extractor in the anterior. I'm not sure if anyone has seen these. Basically it's a wine bottle opener. It's corkscrew. You screw it in. This applies force, pulls the tooth out in the tray, and leaves the tissue in pristine condition. So, critical. It all starts with the extraction. So, I'm sure everyone's heard that if you don't have a buccal plate, you have to graft and come back. And I would say that that's just non-issue in my practice. If the tissue is where it belongs in the first place, we want to maintain it. Best way to maintain it is placing an implant and a provisional to support it. So what do we do when we have no buccal plate? There's a lot of things that we have available. One of them is to do a block graft. So this is a tuberosity block graft. We go to the tuberosity, and I do a split thickness flap, leave some tissue on the bone. I take a chisel, and we take a block from the tuberosity. Tuberosity bone is different than doing a block graft from the mandible because it's very vascular, and you can actually mold it. It's spongy, and you take this and you work it in around the implant like that. So now we have gum graft, bone graft. This is how we make a provisional. I pack collar tape, collar plug around there, and then we pick that up, polish it, deliver it. Here's that technique. Pack it around. Now you've got about a 2 millimeter indent here. And when you go to do the final, it's just super easy. That's also how you can make a custom healing collar. So here's another case. When we look at challenges, when you have thin tissue and very tall teeth with high papilla. So here we're looking at his papilla is probably about 5+ millimeters. Then we're going to have to place that implant 3-4 millimeters below that. We're 9 millimeters up here from that papilla. We're presented with chronic lesion, apicose, no buccal plate whatsoever, thin lingual. Question is, when you look at that, should you be placing an implant into an area that has an active endodontic infection? That's always been the challenge. People have said you can't do that. But here we have all the research that's showing there is no difference in the success rate as long as you've adequately debrided and disinfected the site. So, here we are. Here's that buccal bone graft. And here was the original. And not only did we not lose tissue, actually gained some back. So, original, restored with ideal bone. We have not lost any bone around there. What if you can't do an immediate provisional? Well, this is a custom healing collar, and this is what you can get from a custom healing collar. That sort of tissue is going to be tight. You're not going to have food catching between the teeth. So if you look at it, this is a bit burned out, but when we do a custom healing collar or a provisional, your molars look like molars. And then the other thing is full arch cases. You don't have to take away bone. Works just as well as just do that one tooth several times. So here, place the implants. Here they all are. Angled implants work for crown and bridge. It's just as well as they do when you're doing it in a hybrid. Just thinking outside the box. Here you can see what we're able to achieve. It's a FP1 full arch reconstruction. Yep. Again, it all started with doing the workup, doing the aesthetic treatment plan, looking at the occlusion, and determining whether it can be done. There are many cases that can't be done this way. They do require doing alveoloplasty. You have to have all those tissue volumes present. But when they are there, this is really the most, and this is what I would want to have in my mouth, as opposed to a hybrid, if I could. If you can't. No. When we are working with interdisciplinary teams, I try to think like the restorative doctor. Our restorative doctors try to think like me. And so when we're dealing with implants, you want to try to think like a periodontist. And this is really the junctional epithelium. This is on teeth, we've got to provide that attachment. This is a vital organ, and this is what allows us to keep teeth. When we look at periimplantitis, the rates are alarming. There's somewhere between 20 to 25% of implants right now develop some level of peri-implant disease. And a lot of it's because we're not paying attention to the soft tissue around the implants. So, when we're looking at the tissue, we're looking at the volume, the vertical height, we're looking at the crown, we're looking at the abutment. Thin tissue will thicken at the expense of bone. And that's when we get exposure to the implant. And this opens the door to periimplantitis. Also, the material. If this is gold, or porcelain, or glazed zirconium, what's going to happen is the attachment is going to form down on the implant. There's research on that. Basically, titanium and zirconium is good. Gold, porcelain, glaze, zirconium is bad. The abutment fit, this is getting into the conical connection. Critical, because if you have movement, it's going to move down here. If you have inadequate attached gingiva around the implant, you're going to also have the same thing. And then you get pathologic bacteria on the implant. The other issue is the contour. So you want to have a concave or a zero emergence for the first 2 millimeters. If you have excessive volume here, you're going to actually cause bone loss. And that's a real problem. Once it starts, you get exposure of the implant, you have progressive bone loss around the implant. Critical contours. So we want to have not over bulk, because that'll push the tissue down. This should be a sigmoid shape. So one of the things that's important is that we don't want to allow the lab to just give you any contour. You need to look at those contours, not just how it looks in the mouth. When you put it in, if you're over bulked, you will get recession around your implants. The provisional allows us to test out those contours, and then we need to duplicate those with the laboratory. So here is a case where the provisional had a zero emergence profile, and this is what's coming back from the lab, and you can see what happens: bone loss. This case was placed, looked just like this, was in there for 15 years, put a new crown on, and this developed immediately. So contours are a big part of it. So I'm always preaching about you gotta have the right contours, you gotta have the right contours. Of course, I'm the periodontist, so I don't have to deal with it. But on this case here, we actually took it from start to finish, and I learned some things. So, immediate placement, pristine socket, get the implant in the right place, implants in place, provisionalize, bone graft. Here's where you place the collar plug around there. Very easy to make a provisional on that now. So this is what it looks like. Comes up, put it onto an analog, and then deliver the provisional. And that's what the provisional looked like. Not too bad. So we decided to go to the final. This patient didn't have a general dentist. So we developed a custom subgingival contour. So we take the provisional, put it onto an analog. We immerse that into impression material, like this. That's the analog, and now we have our gingival contour. And this is a custom impression coping, which has the exact contour on it. Here's that tissue. Here's the crown. It's delivered. And then I looked at it. I said, the provisional looked better than the final. But we did everything. Sent everything to the lab. They had everything they needed. It looks terrible. It grew. So I looked back And here's our provisional, and here's our custom impression coping. And this is our final crown. They didn't follow the contours. I didn't check it. We put it in, and we got the soft tissue adaptation. So lab instructions must be explicit and verified, because it's those little things that you don't see that come back to haunt you. So we want to have good contours, and so the BioHorizons contours that are on their conical abutments, conical implants, are fantastic. Make sure you have a lab checklist and only use original manufacturer's components. Emergence profile, first 1.5 to 2 millimeters needs to be straight off of the implant. Titanium or only below the tissue, or polished zirconium. S-shaped contour. Never place porcelain, gold, or cast alloy subtingently. The other issue that I've encountered is the use of tie bases, particularly in the anterior. In the posterior, less of an issue. And that's the other thing is your final prosthesis has to be cleaned and steam cleaned, because basically it is an implant. It has to integrate with the tissue. If you have oils from skin, from the lab, if you have polishing material on that abutment, it's going to cause a tissue reaction. You're not going to get attachment. Little detail. Everything looks right, and just that surface preparation comes back and you're scratching your head, why didn't it work? Again, excessive contour, and then it was corrected. The contour caused gingival inflammation and retraction of the tissue. So tie bases create a problem for the lab in the anteriors. And the reason is that the tie base only has a 0.25 millimeter shoulder. The zirconium sleeve that fits over that is actually thicker than the shoulder. So you wind up getting excessive bulk right here. And if the tie base is at the level of the implant, you're going to have encroachment on the bone right away. So it is possible to use a 2 millimeter tall tie base, because at that point it's away from the bone and you can tolerate that wider width. But yeah, it's ideal is to utilize a custom abutment and do a screwmentable, so that you cement the crown onto the custom abutment. That way you can get your ideal contours, move away from the tissue. So, all right. And I think we're there. We are there. So I covered a lot of material. Anyone would like a copy of that PowerPoint for doing treatment planning, if you just go to this link, put in your email, we'll send you a copy of it. So, absolutely, I'll get you one. So any questions? I flew through a lot of material. Yes? That was when I grafted so much in there to overbulk it. So basically, in order to get to where you want to be with vertical augmentation, you need to graft an extensive amount of tissue in all areas, and that's where that graft came all the way down halfway down the tooth. And then when it finally matured, it was at the right place, yeah.
So what is not a particular technique, it's just something that happens?
Now, it basically is that you need to, if you're doing grafting, you have to way overcompensate. And you have to understand the shrinkage that you're going to be getting, and that the graft needs to extend well beyond the area itself because you need to support it. So that's where you have to have buccal augmentation, vertical augmentation, in order to get it to move vertically. Yeah. Yes?
This might be weird asking a periodontalist, but when you encounter an implant that's in the wrong position,
Yes.
my first thought was to go with pink porcelain to fix the issue. Is that something that you ever encounter, or is it always taking?
So, that's a good question, because there are some cases where that's all you can do. And that's where we would take the case and we would put it into the template and look at what is the possibilities. So, if an implant is buccally placed, it should be removed, if it's in the aesthetic zone. Because right now, we have instruments that we can remove that without creating more bone damage. So in the anterior, if it's buccally moved out there, you're going to create more of a problem. Now, the other thing is it an aesthetic issue? You know, if they have a low lip line and it doesn't show, you don't need the pink porcelain, and you don't need, really necessarily to do anything. You just make it work. But if the area shows in the smile line, pink porcelain, particularly on a single tooth, is very hard to do well. If you're looking at a segment, it's easier, but pink porcelain on a single tooth, very rarely it can be done satisfactorily. So, and you got to talk with the patient. That's always a difficult conversation. Like the patient that I showed you, she did not want to part with her implant. I think that if she had it to do all over again, she probably would have. But we did have that conversation. But yeah, it was a lot. It would have been a lot easier to just back that out and graft the bone and put the implant where it belonged. But that's hard to explain to some patients. So, yeah.
Thank you.
Yeah. Thank you.
Thank you so much. Everybody has to agree after Dr. Mugford's program that, as I said, implant placement in the aesthetic zone is far and away the most challenging thing that we can do in implant dentistry. So we really appreciate you providing a roadmap for us, and we'll be calling you if we have some questions.
Absolutely. Thanks so much.
Thank you.
Appreciate it.
So that's it for this evening. I don't know